All right, good afternoon, everyone. Welcome to Medicine Grand Rounds. It is 12 o'clock, so we'll get started. My name is Vineet Chopra. I will be introducing our Grand Round speaker today and moderating our session. As a reminder, for those of you who are not in the room and virtual, we are in person at Krugman Hall in RC2. I encourage all of you, as always, to come in person for Grand Rounds. Not only do I think this is a better experience and we all come together as a community, but you also get lunch when you're in the room. So if you can, please do. I think it's a different experience and one that I would highly recommend. For those of you that are virtual, please remember you can put questions into your chat box. Our chief residents, as always, are here and will monitor the chat, and we will get to your questions in the Q&A session. CME and mock credit are available for Grand Rounds today. Please scan your QR code up here on the screen or on your screens at home and sign up for your CME or mock credit. A quick preview of what we have coming up. Next week, May 3rd, Dr. Alicia Fernandez will be here to deliver the Mickeljohn Lecture. Dr. Fernandez is professor of medicine at UCSF. She's a general internist at Zuckerberg San Francisco General Hospital, Associate Dean of Population Health and Health Equity for the UCSF School of Medicine. Dr. Fernandez's research focuses on healthcare equity in chronic disease, particularly in diabetes and racism in medicine. And I know I've heard her speak before on this topic. She is eloquent, articulate, and compelling. So I hope you all join us here for that. Following that, an even better presentation by our very own chief residents on May the 10th. This is a crowd favorite. I've heard some things about the session, and I can tell you it's going to be riveting. So please do come. No pressure on our chief residents on performance, of course, for that as well. And now it is my pleasure to introduce one of our very own, Dr. Pratiti Khazani, who is going to give Grand Rounds today for the Department of Medicine. Dr. Khazani is associate professor in the Division of Cardiology in our department. She completed her bachelor's at Duke University, earned a combined MD and PH also at Duke, and then went to the UNC School of Public Health, where she got her master's in public health. She then migrated to the West Coast to Stanford, where she completed internship, residency, and chief year in internal medicine. She then returned to Duke following residency to complete her cardiovascular training and fellowship and advanced heart failure fellowship also at Duke. We were fortunate to recruit her in the department in 2015. She has since risen through the ranks to associate professor. Dr. Khazani is currently supported by a K23 award from the NHLBI, which is focused on understanding variation in the use of heart replacement therapies among patients with advanced heart failure. She's also received grant funding from the NIH in the form of an ethics supplemental grant. She's got funding from the Doris Duke Foundation, the American Heart Association, and some industry partners as well. Dr. Khazani has published 34 peer-reviewed articles in leading cardiovascular journals, including Circulation, the American Heart Journal, Circulation Cardiovascular Quality and Outcomes, JACC Heart Failure, and several others. In 2021, she was a named author on the Universal Definition and Classification of Heart Failure report. This is a joint report from the leading heart failure societies all over the world. She is now a member of the AHA-ACC Joint Writing Committee for Cardiovascular Guidelines. In fact, chairs the Ethics in Advanced Heart Failure Transplantation Scientific Statement. In 2019, she was the recipient of the American College of Cardiology Emerging Leader Faculty Award. I could go on and on, but I think you get the point. Please welcome me in joining Dr. Khazani for her talk entitled, Don't Hate the Player, Hate the Game, Ethical Challenges in Heart Transplantation. Welcome, Dr. Khazani.
Thank you so much. Thank you, Dr. Chopra, for that very kind introduction. I was not expecting that. I wanted to say for the chief residents, I remember giving that Grand Rounds when I was a chief resident, except I was 9 months pregnant. Couldn't see my feet and wore 2 different shoes, not realizing until I was up on stage. So hopefully that doesn't happen to you, but it was very memorable. I will never forget that. So today I'm going to talk to you about ethical issues in heart transplantation. And it's a subject that's near and dear to my heart. No pun intended. But pun intended, don't hate the player, hate the game. So I have funding through the NIH, an ethics grant, Doris Duke, and the Ludeman Center for Women's Health Research here at the university. So I just wanted to go over a few biases that I have. I am a registered organ donor. I'm a heart failure transplant cardiologist. I'm chairing an AHA statement on ethics in transplantation, and I believe that clinicians should be more involved in making policy and should be involved in ethics as well. So overview, I'm going to go over the basics of ethics. So some of the terms that you're going to hear about throughout your medical training. I'll talk to you about evaluation, selection for advanced therapies, organ allocation, new frontiers, and then how we translate ethics into health policy. So solid organ transplantation is a very different thing compared to any other type of field in medicine. So in the US, we really don't deal with scarcity until COVID hit. So we weren't people who could go through medical care and really think about a lack of anything. So solid organs are the ultimate scarce resource. And if you think about it, about 17 people die every day waiting for a transplant of some sort. And in heart transplantation, unlike say kidney where you can do dialysis, there aren't great options other than potentially an LVAD, which is not yet an equivalent therapy. So we'll go over some ethics basics just to go over the pillars of what we're going to be talking about. So number one is autonomy, non-maleficence, beneficence, and justice. So in terms of ethics in transplantation, we talk a lot about beneficence and non-maleficence. So what does that mean? It means do no harm, so what we say in the Hippocratic Oath, but it also means when at all possible, do good. Then in terms of autonomy, we all know what this means. It means to consent someone that the patient has an understanding of what they're going to go through. In terms of justice, we talk about distributive justice. There's also other types of justice, which we'll touch on in a little bit. Allocation and supply. And then finally, we really focus on equity in terms of fairness and making sure that people get what they need to get where they need to be. And so we've all seen this figure of what reality looks like versus equality, equity, and then what justice we hope to serve to our patients. So in terms of rules of transplantation, there are certain rules, unwritten rules that we all talk about. One of them is the rule of rescue, the desire to save those facing death with little regard for cost. So if you look at heart transplantation, it's really not the most cost-effective therapy. Could we use that same money for vaccinating children or doing other things? Potentially we could, but in the end, we have a lot of people who are dying. We have the ability to transplant people. And so we believe in this rule of rescue, that if someone is dying, particularly in this country, we will do anything to help save them. There's additional rules of transplantation that we often talk about. So rules of engagement. So one of those rules is called the final rule. So the final rule in transplantation implies that there is a mandate by the government to try to give patients who are the sickest organs. And if you're not as sick, maybe we shouldn't really focus on that. And we should do that regardless of where you live in this country. The dead donor rule, which we'll talk about a little bit later, prohibits causing death by organ removal. So we don't want to just go into a live patient, remove their organs and transplant them into someone else. And then another rule that we don't really talk about as much, everyone wants to talk about patient-centered care. But one thing that we need to start thinking about more is patient-driven care versus patient-centered care. What are the differences? And there are differences. So we have a lot of different support options. We have patients who are more and more engaged now. And so sometimes patients may come and say, I don't want an LVAD, I only want a transplant. That can be a sign of patient-driven care rather than, say, patient-centered care. There are multiple nuances, but we can get into that. So there's lots of things that we have to think about in terms of transplantation. Before we ever get to transplant, we have to start with an evaluation. And it involves a medical and a psychosocial evaluation. And one of the things that we always think about is that transplantation in an advanced heart failure center, what we're good at is evaluating and selecting people. We have no idea what's going on upstream. But for the sake of this talk, I'm going to talk about the evaluation and selection processes. So once they get to us, one thing that we've looked at is the psychosocial evaluation is completely broken around this country. So the medical evaluation is very, very regulated in transplantation because it's a scarce resource. So there are strict rules about what will allow someone to get transplanted versus not. The psychosocial evaluation, not so. So our team here, led by my partner in crime, Chris Konopke, who's in the audience, we looked at what the requirements were for a caregiver for someone who was looking for either an LVAD or a transplant. Now, the title of this is LVAD, but in reality, this is true for transplant too. And this is something that came out of my own clinical experience. When I trained on the two coasts, one institution required a caregiving limit for 1 week, one required a caregiving limit for a month, and then here we had a caregiving limit for 3 months. And so if they did not have a 24/7 caregiver, then they were not allowed to proceed with transplantation or LVAD. And so is that really fair? Is that something that we should be doing? And that's one of the things that we have looked into. Should lack of social support prevent someone from access to transplantation? These are ongoing issues in all of transplantation. But that's one of the examples of how ethics can kind of permeate into clinical practice. The place that we really see it the most is with selection, when we're trying to select for different types of therapies. How do we do that? So we do that in a multidisciplinary selection meeting, and then we make these life-altering decisions for patients. And it's a high-risk, high-reward therapy, no matter what you do. And there are 3 different things that we could do. We could either go with invasive therapies, so things like transplantation or LVAD, and I call them heart replacement therapies. Or we could go with palliative care and hospice. And so the way we do this in this country is very variable depending on where you are. There's a lot of regulations in terms of multidisciplinary teams who sit on these committees. So it's very regulated in terms of heart transplantation. We have a prescription of who has to be in the room where it happens, to quote Lin-Manuel Miranda, when we're making these decisions. But for MCS, not really the same. MCS stands for mechanical circulatory support, or LVADs. And so to transplant or not, who decides these things? It's done in the committee, and we look at medical, surgical, psychosocial considerations, but there's a lot of variation in the country. And then if you think about the different types of therapy, so MCS, as I said, is the same as LVAD. So if you're looking at an LVAD, it doesn't last as long. The average lifespan for an LVAD, now it's increasing. It used to be around 50% of people would be alive at 5 years. Now that's longer with new technology, and we're improving that over time. But the lifespan for an MCS is lower. Transplant is around 13 years. So we look into a lot of things like operative risk and RV function, infections, cancers, how much weight should psychosocial considerations be given. We also try to look at some patient autonomy in terms of their preference of what types of therapies they'd want to have, LVAD, transplant, but we have to be careful, as I said, for patient-centered versus patient-driven care, and we can get into that in a second. So in terms of organ allocation, we're trying to balance 2 things, and there are 2 really big principles in medicine. So one is the AMA Code of Ethics, which says that a physician's primary ethical obligation is to promote the well-being of their patients. So if you are taking care of a patient, your ethical obligation is to that individual patient. The problem is, for transplant physicians, organs should be distributed over as broad a geographic area as feasible. This is the final rule that I was talking about. So we're charged with giving organs to the sickest patients possible. Well, what if that sickest patient isn't our patient? How do we figure that out? So we're always trying to balance the individual versus the population. And it can be a really difficult thing to do. So when we're doing this, we're trying to balance utility and justice. So standardized organ allocation criteria that are equally accepted and applied are meant to balance these 2 things. But there's a lot of politics involved. And so I'd like to quickly go over some of the politics of geography in transplant allocation, because it's really important to understand this historical context, even though it is slowly going away. So this is a map of the United States. All the green spots are where we have heart transplant centers. And if you look at it, so we are the only heart transplant center in 500 miles. The other one is Children's. So the National Organ Transplant Act in 1987 created something called the OPTN. And it's this organization that standardized the process through which organs are donated and shared in this country. It created the system of something called OPOs. And they're managed under contract by this private group called UNOS. UNOS is in Richmond, Virginia. All OPOs are regulated by multiple government agencies. The country is divided into 11 transplant regions. We happen to be in region 8. So there are 58 donor service areas, and they're managed by these organ procurement organizations that are all private. And so then you have other issues where there are antiquated borders where these DSAs used to exist, and those borders were created by Congress. So it's not necessarily where people live. Sometimes there's a lot of disparities. Some OPOs have more access to organs than others. And there's a lot of variation in a lot of things. And one thing I didn't even realize is New York's OPO gets a lot of flack. They don't have a lot of drivers. So they actually don't have a lot of donors because of multiple factors, but that's one of them. Our helmet law in Colorado actually favors us getting organs because there's not a really strict motorcycle helmet law. And in the old days, we used to decide organ allocation based on donor service area. So if you were at a center, then as you went farther out, the first people who would get organ offers would be more local, and then it would go further out from that geography. So in the old system for transplant allocation, note this. So New York, it used to take over a year to get an organ. Whereas if you were in California, it took a little over a month. So there are huge variations in the country. And because of this, some centers had bragging rights. So this is something from when I was in fellowship. I was in Texas, and this was on a billboard. And so there were some people who couldn't get an organ within a year and a half and were dying on the list. And then other people had these types of things on billboards in major airports. So there's also been issues with wealthy people being able to go to other areas to get organs. There was something that was just published this week in the Journal of Cardiac Failure, which I'll talk about in a second. But if you all remember Steve Jobs, when he needed his transplant, he was in California. He couldn't get listed where I was, and he ended up taking a flight, a private jet to Tennessee, and got an organ. Their wait list was shorter. There's also been turf battles for organs. So this is one of the most interesting cases I think I've ever heard. So this is a woman named Miriam Holman in 2017. So she was in New York dying. She needed a lung transplant. And across the Hudson River, the wait time was lower. And so someone else got transplanted in New Jersey, and she sued. This happened over Thanksgiving week. And so despite it having all these things going against it, they actually changed the lung allocation policy during Thanksgiving week because they decided that the organs needed to go to the sickest patients possible. The final rule once again. So heart transplant allocation has gone through multiple changes. There's been 4 in all. It was first started in 1988, and over time from 1988, then there was another one in 1999. LVADs came about around the early 2000s, so they really changed the game because they were another therapy that we could use to get people to transplantation. Originally, they were approved as bridge to transplantation, or BTT. And then eventually, when I was in training, they became destination therapy, so people could get LVADs to live with an LVAD for the rest of their life. And they really did change the game because people with LVADs actually bumped up to the top of the list. So they got priority. And then we had these criteria change with some geographic changes. But the main thing to note is that in this time, most of the people who were getting transplanted were listed as status 1A. A lot of them were sitting at home with an LVAD. And so they weren't necessarily sick, but they were sick based on the criteria that we had. So the goals of the new heart allocation system were to reduce waitlist mortality rates for the sickest patients, because the old system, pre-2018, a lot of people who were super sick, especially in areas where it wasn't as organs weren't as available, they were dying on the list. They wanted to reduce the use of exceptions. So exception letters are things that we can write saying, my patient actually doesn't fit this criteria. They need to be bumped up on the list. And so they wanted to decrease the number of exceptions. They wanted to create criteria based on objective physiologic indications rather than therapeutic interventions. What does that mean? That's a mouthful. So what that means is they wanted to use hemodynamics. So in the old days, at the top of the list, you could be on inotropes or have a balloon pump, and that would put you at the top of the list. And we didn't have hemodynamic criteria. It was kind of based on whether or not we wanted to put in a balloon pump. We felt that the patient was in cardiogenic shock, but there were no strict criteria for hemodynamics. In the new system, they've created all these rules. There's a lot of rules. So many rules that we have to have a sheet on our table and go around and say, oh, are they checking off all these boxes? Can we fit this patient into this category versus that? So there's a lot of hemodynamic criteria and organ damage. There's specific doses that we're allowed to use for inotropes like milrinone and dobutamine. And so this figure is busy. I don't want to go over all the details, but the one thing to note is that the 1A status, the top of the list that was from 2006 to 2018, that got divided based on what people thought would be the sickest people who would potentially die without a transplant. And the way they did that is status 1 became, and I've simplified it here. There's a lot of things here, so it's busy and I wanted to simplify. Status 1 is mostly ECMO. Status 2 is an unstable LVAD, balloon pump, or a total artificial heart. Status 3 is high dose inotropes, but multiple inotropes. Status 4 is a stable LVAD or low dose inotropes. And then 5 is a combined organ transplant, something like heart, kidney, heart, lung, that sort of thing. And 6 is people who are living at home. So we're trying to do this based on how sick people are. There were certain assumptions that we made. And so one of them was that there was no change, that there would be no change in practice pattern. That's kind of a bold thing to assume, but that's what we assumed. Use of technology would be commensurate with physiologic patient needs, meaning that if a patient had certain hemodynamics, they would get certain therapies, and that there would be no fudging of the hemodynamics. And then adherence to intent of revisions. So the intent of the revisions were to decrease gaming, were to decrease exceptions, were to increase the chance of people who are super sick getting an organ. So there are some things that have really worked in this new system. And so I don't want to just stand here and criticize it completely. So there has been greater geographic sharing post-policy change. So this is an interesting study that was done by Dr. Globus at Michigan. And they looked at the proportion of organs that were shared. And if you look at red, orange, that indicates that there was more sharing in those areas. Okay, so more sharing post policy change. That's the take home from this slide. The one thing is in 2018, this policy changed. Well, what happened? We had increased use of temporary mechanical circulatory support, an increased use in, slightly decreased use of LVADs actually, Increased use of balloon pumps actually went way up. Exception letters went way up and continue to skyrocket. And then high dose inotrope use has gone up a little bit. But the main things we've seen is balloon pump. More recently, we're seeing more ECMO. So I was invited to be a collaborator on this paper by my former clinical mentor, Joe Rogers, and he actually was the person who wrote the allocation change for 2018. So it was always interesting when I would debate with him about the pros and cons of why they made certain changes. The main thing to point out is that in terms of overall, what we came away from this with is that donor ischemic time and distance traveled went way up. We actually, a lot of OPOs blew through their entire budget in the first few months. So the cost went up. Procurement and index heart transplant hospitalization costs went up. ECMO, balloon pump, exception use went up. ICU, MCS, or ventilator use at listing went up. And then the highest priority listings went up, but they went up for a reason. And we'll go over that in a second. Wait list times went down, mortality, it's debatable, but most people say that it went down or stayed about the same. Post-transplant mortality went down, decreased time to transplant with LVAD complication. The one thing is there's hardly any bridge to transplant LVADs that are being done now in the country. That's a big deal. And we can talk about that more at the end, but that's a really big deal. So now we are preferentially pushing people to transplantation instead of LVAD. There is a belief in the community that transplantation is superior. It is most of the time, but sometimes it's not. And so we can debate that at the very end. The other piece that's really gone up and something that I'm very interested in is how these exceptions work. So there was the International Society of Heart and Lung Transplant was just in Denver last week, and there was some really interesting work being done around this. And what we're seeing is that people are writing exceptions for patients who may not really need it. And in the letters, people can write certain things and they're reviewed. And as some of my colleagues have pointed out, if you want to turn down the exception, you have to write a long paragraph and give a reason. If you want to accept it, check, move on. So now, in terms of exceptions, around 30 to 40% of all status 2s are getting their transplants by exception. Around 20 to 30% of all status 1s are getting their transplant via exceptions. The exception rate has gone way up. Not the original intention at all. Some of that has to do with the procedure of how we go through evaluating these exceptions, and that gets to procedural justice, which we'll talk about in a little bit. So we all want to do the right thing, right? And we also know that cheating is wrong. But I really like to turn to the social sciences for some of this. So Dan Ariely at Duke came up with this whole concept of the fudge factor. And if you haven't listened to his podcast about this, it's hilarious because he talks about how he pretended that he couldn't walk so that he could get on an airplane and kept on going with that same fib for quite a bit just so he could get preferential treatment. But he said, you want to be able to look at yourself in the mirror, but you also want to be able to cheat and benefit from that cheating. So why is this a problem? So it's a problem because if you're focusing on the individual patient, there's subjective factors that can impair a patient's functional status and make the use of high dose inotropes or balloon pump inappropriate potentially. You could also, overtreatment may lead to the shorter wait time and the difference between life and death. So in some ways you could be helping the patient, in other ways you could be hurting the patient. In terms of justice, there's excess cost, risk of therapy-related complications. So we're using all these invasive things. And I showed you data showing that balloon pump use has gone up, ECMO use has gone up, and a lot of other invasive therapies are going up. So there is a risk of therapy-related complications. The one thing I'd point out is that we are seeing better outcomes. Potentially we're seeing better outcomes because we have a different balance. Potentially we're putting in these therapies in people who may not really need it. And how does that happen? We'll talk about that in a second. So, and you can also unfairly elevate the status of a less urgent candidate while truly urgent candidates die. So how many of you have ever seen a right heart cath? Show of hands. Okay. During a right heart cath, there are things that we can interpret. So hemodynamics are not always concrete, right? So what we know about hemodynamics is if you have a cardiac index of 1.6 and the other one says 2.0, which one are you going to pick? You're going to pick the lower one because it benefits your patient. You're technically doing the right thing. You're helping your patient. But in reality, you may be hurting someone else. So a lot of that is happening because of this whole concept of scarcity. Also, it's tipped the balance for transplantation and LVADs. So LVADs, while they don't last forever, are not a terrible therapy either. And there's some people who may not need a transplant, who may not be the type of person that we would have transplanted before. If you look in the country, we are starting to transplant people who we would not have transplanted in the past. There's multiple reasons for that. We have more organ availability from the opioid epidemic. We have donation after circulatory death. We have a lot of reasons for that. But at the same time, it is shifting this balance quite a bit. And there are patients who potentially could have been given more life. And what we have to start thinking about is instead of focusing on transplant only, what, from the patient's point of view, how can we get them to live as long as possible? Sometimes that may be doing something like an LVAD and then bridging them to a transplant. That's something that we debated at ISHLT last week because we've become so singularly focused on transplantation. So because of some of this, I was really interested in some of the ways that clinicians are dealing with these dilemmas. So during COVID, I was morally torn about what we were doing. And so I started this qualitative study. I actually interviewed all these people, including cardiologists and surgeons all over the country. And people, because I'm a fellow heart transplant cardiologist, just talked to me. They were very open and honest about their experiences. So there was one person who said that they felt forced by the system to use mechanical circulatory support. Another one said, I'm hurting my patient because I'm too much of a rule follower. I'm not writing exceptions. I'm not upgrading people to a balloon pump when their hemodynamics are marginal. And I may actually be hurting my patient while I'm helping someone else. And then another one said, there's no world in which putting a balloon pump is the right thing. So they noticed that in the old days, they would have never put in a balloon pump in that particular patient. They would have tried to bridge them with inotropes or do something else. And in this case, they were putting in things that they normally wouldn't have done, and they felt terrible about it. So what does this mean? So there's this whole concept of moral distress. How many of you have heard of moral distress before? I think it's a huge thing in the literature right now, especially in other areas of medicine. So moral distress was really they started talking about it in the 80s in the nursing literature. And it's when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. It's a perceived violation of one's core values and duties. And you also have this feeling of being constrained by taking ethically appropriate action. So there's internal constraints and external constraints. This is a figure I made because there is such a thing as moral distress and then moral residue. Over time, we creep a little bit. We make a change and then and there we go. We have this increased distress about some sort of change. Then we start doing things that we normally wouldn't have done. In the old system, we started listing people as 1As. We started putting in LVADs potentially to help people bridge to transplant. We developed this kind of comfort with what we're doing and developed something called moral residue. Then the allocation policy changed, and we keep making these changes. And over time, there's this crescendo effect. We get used to the new normal. And so that's a really powerful thing to think about when we're making these life or death decisions for patients. So I'd like to close with some of these concepts of donation after circulatory death, and I see that Dr. Hoffman is in the room, so we'll have some good discussions with that. Vaccination requirements in transplantation, and then substances, and then we'll go through some of the end stuff. So donation after circulatory death, or DCD, the first heart transplant that was ever done was actually a DCD. The one done in South Africa by Christian Barnard in 1967. Circulatory death was the only formal definition of death at the time. And so what they did is they had the donor and the recipient close to each other to minimize what we call warm ischemic time, and they transplanted the heart. So when we started doing organ donation and organ transplantation in this country in the 80s, one of the things that came out of it was we started talking about, what does death mean? And there is a legal definition of death by statutory or case law, but there's also something called the dead donor rule, which is an ethical norm. It's not a public law or regulation or policy. It's just something that we agree to. It's recognized by all 50 states currently. The way it was originally written in 1981 was that an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. And so the dead donor rule in ethics is important because we talk about autonomy. So you're trying to honor the donor's wishes, non-maleficence and beneficence. You're allowing for respect for the end of life with that patient. You're preventing harm to the potential donor. That potential donor is still a patient. After they die, you're trying to minimize harm to the donor because now they've transitioned into becoming a donor. And then we also think about justice or equity, overrepresentation of socially vulnerable groups in this donor pool, particularly people who are coming in with donation after circulatory death. So the question right now in our field, and it's a hot topic, is the dead donor rule outdated? So there is some concept of maybe we shouldn't use the term irreversible anymore. Everything's reversible in medicine. We have so many changes in what we do since 1980s that perhaps we should think more about something being permanent. And this is where we get into a lot of debate. So there is this concept of permanent cessation of circulatory or respiratory function and permanent cessation of all functions of the entire brain. So we'll get to that in a second, but this is the traditional pathway or organ transplantation. The organ donor is brain dead, and then it goes to the transplant recipient. Seems simple. Now we have this new pathway that we've started, and it's donation after circulatory death, DCD. And donation after circulatory death, there's something called the direct procurement perfusion system. I call it the heart in a box. So we can just call it that. It's a very expensive machine that was under clinical trial, not currently being used here. There's also something called normothermic regional perfusion, where you use ECMO and other invasive therapies to help keep the organ going. Some of the seminal work originally was done here and then also by one of our own transplant surgeons. This whole system has increased the donor pool by 30 to 50%. It's decreased wait list times and mortality, increased the transplant volume, and increased transplant indications. This is the Transmedic system, the heart in a box. It's incredibly expensive. I wanted to highlight some work done by Jordan Hoffman. So he's in the audience. He's one of our cardiothoracic surgeons. When he was our fellow and then went to Vanderbilt, and then we snagged him back. He looked at the early US experience at Vanderbilt with cardiac donation after DCD using this normothermic regional perfusion. Jordan, we can talk about this at the very end. But there has been a lot of debate about NRP. And so some of our own folks, so Matt DeCamp in internal medicine, and then some other groups have done a point counterpoint just recently in CHEST, looking at the pros and cons of NRP. Without getting into all the details, it's more based on what we consider as dead. And we can go over that in a second, but there's a lot of variation in the world in terms of who uses these therapies and who doesn't. So if you look around the world, there's certain countries, for instance, Australia will not do NRP, but they will do heart in a box. If you look at the US, we're doing both, and our transplant volumes have gone up. And there's, this is a little macabre, but you know, there's this whole concept of
mostly dead, he's slightly alive.
So how many of you recognize The Princess Bride? That was The Princess Bride. But every time I think of that, I think of both Monty Python and the Holy Grail and Princess Bride.
Yeah.
In terms of, there's a difference between being mostly dead and all dead. So that whole concept of irreversible versus permanent, what does that really mean? And so there's been a lot of debate. So we'll talk about that at the very end when we're in our discussion phase. But overall, there's also been a lot of work looking at COVID vaccination. So if you look around this country for organ transplantation, there's been a lot of controversy about whether or not people need to be vaccinated for COVID before becoming eligible for transplantation. At our institution, we require it. Most institutions require it. There are some centers in other states where the higher ups have said it's not a requirement, but the transplant program itself is not keen on transplanting people who are not COVID vaccinated. And the reason for this is nice work done by Laura Peters, who's a DNP in our group. People who have COVID, who, even if they're vaccinated, but people who have COVID and a transplant are more likely to die. So we're potentially wasting that organ on people who are not doing the normal preventative care. And all along, flu vaccination has been a requirement. So we're trying to say that this COVID vaccination issue is similar. Also, there's been more work done about cannabis use in transplantation, not just heart transplantation, any transplant. The reason is cannabis, even though it's legal here, it actually interferes with all the immunosuppressions we use. So I actually admitted a patient yesterday who has been using marijuana post-transplant and is potentially rejecting his organ now. Because the levels of Prograf and other immunosuppression vary so much with the use of marijuana. There's also a lot of concern that this disadvantages certain populations, but it's an ongoing area of debate whether cannabis use is okay versus not. Then I'd like to close with ethics and how we translate that to policy. So ethics, people have an issue with it sometimes. It can feel very ivory tower. I'll be honest, I often feel like it feels very ivory tower. Versus the people who are actually taking care of patients who have boots on the ground. So how do we merge this together? And this is why I wanted to talk about this a little bit more in detail. So we have all these ethical constructs that we're trying to balance and that we're trying to work on to improve the care of our patients. We want to do what's right by our patients. Who better than people who are actually taking care of these patients? So I think there's a role for ethics in all of clinical medicine. There's a role for it in the ivory tower as well. But I think there's an understanding of what patients go through and what we go through as clinicians that a non-clinician may not be able to understand as well. And if we want to work on moral distress, some of what we'll have to work on is trying to figure out how to make this whole process more fair and working together with people who have a better foundation in theory and justice and distributive versus procedural justice. So distributive justice, it's what we talk about in transplant allocation all the time. Are the outcomes of the results fair? Are we giving the organ to the patient who's the sickest? But then there's also this procedural justice. Is the procedure fair? Is the process fair? Right now, we've done very little to look at how we're doing the process. That's something that we need to reflect on as a community. One thing that was really interesting when I was reading the point counterpoint for Matt DeCamp's pieces is DeCamp and his group said transplant communities should not be involved in these DCD decisions. And that's one area where I would disagree. I think it has to take both sides coming together to discuss all these issues, because there is something to be said for the donor wanted to donate their organ. There is something to be said for we have a sense of ownership of these organs and trying to make sure that we do right by these organs and give it to people who are going to take good care of it, and that we're not trying to game the system. And some of that is going to be on us as transplant physicians, and some of that is going to be on the community. So there is this new movement called continuous distribution. It's brand new. Heart transplant has never had an allocation score. Unlike lung, kidney, liver, etc., we don't have a MELD score. We just, patients sick, we put in a balloon pump. Their cardiac index is low, we put in a balloon pump. That's what we do. But there's no score. And that treatment, putting in that balloon pump or putting that patient on ECMO or something else, catapults them to the top of the list. And so now we're trying to create something called a continuous distribution. It's something that UNOS is working on for all of organ transplantation. How they're doing this is still not known. They have gathered a lot of data through the 2018 allocation change from all the transplant centers, because we've been collecting all these hemodynamic data. We're trying to balance medical urgency, post-transplant survival, candidate biology, patient access, placement efficacy, and coming up with a score. And then each match run will have a different score, and then we'll figure out where the organ goes. It's still a blur in terms of how this is going to happen. But I think it's important that we are involved as clinicians in a lot of these decisions, because we often say, don't hate the player, hate the game. It's not my fault. Everyone else is doing it. And the game is to be blamed. But in the end, we have to kind of step up and help write some of these rules and really think about how we're making decisions, how we're allocating scarce resources to people, how we're deciding whether one person gets something and the other doesn't. So with that, I'm done, but I wanted to I'm very grateful. So over COVID, I will say that we lost a lot of family members and a lot of friends, and it really made me reflect on how I have gotten to where I am. And I wanted to thank all these people who have been on my side for a long time and helped me through a lot of things, both research and otherwise. Specifically, I wanted to mention Sarah Perman, Christine Jones, Lavanya Kandapalli, Chris Konopke, and a bunch of other people, Caitlin Erpenbeck, who's my right arm. My other right arm is Leslie Meyer, who's a heart failure nurse in the audience. She has kept me going through everything. And without her, I would not be able to do the things I do. This is our incredible team that we work with for advanced heart failure. I also wanted to give a kudos to my mentees, who I'm very proud of. So Jackie Urban, when she was an intern, I turned to her and I was like, you should think about cardiology. And she said, I want to do primary care. And I'm sorry, Katie, I'm sorry for snagging her, but it was my golden moment. And then Samantha Coffer-Thielen is going to be our chief resident. Similar thing happened with Sam. And I'm very proud of her too. And she's doing some incredible research in diabetes and heart disease. And then Kate McLeod, same thing, intern experience. And she got the STAR Fellowship and the NIH Collaboratory Fellowship. So she is well overfunded. So I had to have a talk with the NIH a few weeks ago about how to allocate her money so that we could do more things. I also wanted to thank, so Sharon Hunt, I was going to be an ID doctor. I met this woman named Sharon Hunt at Stanford when I was an intern. And this is partly why I'm so passionate about what I do. But Sharon is the original heart transplant cardiologist. She's like this really petite, redheaded woman. She's older now, but she was the one who came to me and said, I think you should be a cardiologist. And I was like, no. And then she convinced me. But I also wanted to thank my family, my parents and my siblings, and my two beautiful children, Rishabh and Kavya, and my husband, Yogi. And so thank you. Thank you for having me. And we'll open the floor for questions.
That was great. Okay, great. Thank you. That was awesome. For lots of questions. I'm not going to get into the ethical questions because I'm still wrapping my head around some of this. But my first question is, why, with a resource that's so scarce and a procedure that's so complicated and a post-procedural course that can be unpredictable, why do we not have a MELD score equivalent for cardiac transplantation?
Yeah, good question. So one, I don't know. You can answer this if you want as a surgeon, Jordan, but I don't think heart transplantation is necessarily the most complicated surgery compared to some of the other surgeries our surgeons perform. But I think one of the reasons why we didn't have a MELD score for heart transplantation is what's been explained to me when I talked to Joe Rogers is this data actually was never collected. So UNOS didn't ever collect all the hemodynamic data for patients. That was never required. And so we would have a little bit of someone's electrolytes. We wouldn't necessarily have their lactate. We didn't have all the other data elements we needed to create a score. So one of the reasons that the 2018 allocation score is so onerous is because they wanted to collect a lot of this data. So now they're creating more risk scores based on those data and using that for the continuous allocation.
So Pratiti, that was great. My name is Jordan Hoffman. I'm one of the cardiac surgeons. And actually, it's funny you asked that question because I was approached by a PhD from the Transplant Center and he wants to come up with a MELD score for cardiac. So that's coming down the pipeline. It has things like EF, bilirubin, sodium, serum sodium, and some other things. And it's just in this very early stage. So it may be 6 months before we see anything. But I was going to ask you about, which I won't because we'll talk about DCD. I wanted to know, well, I was going to ask you about how you felt about non-transplant LVAD centers in the setting of this new CMS rule that doesn't require them to have an affiliation or association with a transplant center. I mean, I don't love it, and we could talk a long time about it. The other thing I'm curious about, and I've done some of these calculations on my own with the DCD stuff, is the TransMedics device costs $70,000, and that's different from center to center. It's anywhere from $60,000 to $80,000, depending on who the contract is with. That's non-recoverable if you don't use the organ. It's another $20,000 if you use their team to put the heart on the box. That is versus at our center, maybe $4,500 for one NRP run. So the TransMedics device will give you a heart. So each organ is somewhere between $70,000 and $100,000. Using NRP, you can get a heart, lungs, kidneys, liver, pancreas, bowel for about $4,500. If you translate that into how many runs you can do about 10 donors for every one NRP run or one TransMedics run, or 32 organs can be procured for every one on the TransMedics device. And that's about 40 to 1 if you look at places like UC San Diego who use a simpler system. So in speaking about equity, how does that play into the calculus? And I know the ends don't justify the means, meaning there are some people who are on the fence about the ethics of NRP, but how does that play into the calculus of equity and justice for our patients?
Great questions. So I'll start with the first one. So Dr. Hoffman, who's one of our cardiothoracic surgeons, the first question he asked was about LVAD only centers. And just to give you some background, in this country, LVADs were approved originally for bridge to transplantation. So originally approved for bridge to transplantation, and then in 2010, approved for destination therapy. Destination therapy meaning the patient has that therapy for the rest of their life. We used to have this rule that if someone was going to get an LVAD, they needed to be evaluated, especially if they were being evaluated for a DT LVAD, destination therapy LVAD. They had to be evaluated at a transplant center and turned down for transplantation before they could get an LVAD. Now, if you go to certain parts of the country, they don't have transplant centers. And so there's been this debate about equity and making sure that we have equal access to care. So there have been a lot of centers that have opened up that do LVADs only. So they're called, we used to call them DT LVAD sites. And so in order for them to implant an LVAD in the old days, they had to come to us or another transplant center, get turned down for transplantation, and then they could get the LVAD at their center. CMS, a little over a year ago, passed a rule saying that we will no longer require DT versus BTT designations. And so now, because it can be financially lucrative for a center to open up as an LVAD center, there's a lot of LVAD centers that are opening up in the US. They do not necessarily come to us beforehand to get turned down for transplantation. And a lot of them will get an LVAD. And after you get an LVAD, sometimes it makes transplant harder. Sometimes people can get sensitized. They can run out of money. I mean, there's a lot of things that can happen to patients in that setting. So I think it's a mixed bag. I think I actually wrote something on their website when CMS proposed that, as did some other people. I didn't do it under my own name, but under the AHA. I think the fact that we now have independent centers where patients don't necessarily get a fair shot at even being evaluated for transplantation can be problematic if it's done in the wrong way. So I think that is a really tricky issue. I know why they did it, because they wanted more centers to open so people had access to some sort of heart replacement therapy. But it has its issues. Second, your second question was about the heart in a box, basically, and the fact that the heart in a box costs a lot of money. And so it was just under clinical trials. It was only used at certain centers. Most of those centers are very wealthy and have very wealthy recipients. Not all, but some. And so the problem is that you could use all this money for transplantation to fund this company that creates the heart in a box, or whatever future company that creates heart in a box. Instead, you could do the same thing more economically and transplant more people. I think that's balancing both things. I think one of the things is, so in Australia, so I didn't get into all these details, but DCD is done two ways, the heart in a box and then NRP. NRP, Jordan can explain it very well, but what we do is the patient is imminently dying. They haven't yet died of brain death or other things the way we normally describe it. They have expressed a wish to donate their organs, just like we would withdraw care from a patient at the end of life. We stop all their therapies and we see if they have signs of, there's a hands-off period for a period of time, and it's different in different states, usually around 5 minutes, sometimes longer. Hands-off period, you watch the patient, and then if they die, then you go ahead and procure the organs. How you procure the organs, two different ways. One is with the heart in a box, where you cross-clamp the aorta and do all these other things. With NRP, we cross-clamp the head vessels. There's been some concern that, well, once you cross-clamp the head vessels, the heart's beating again, they're not really dead. And so that's where the whole concept of irreversible versus permanent comes from. So I think it's a language thing, and in my opinion, but there's some countries where they feel very firmly that if you're cross-clamping vessels, then you're doing some harm to the potential donor. But there are multiple reasons why we do that. One is if you don't do that, then there's a cytokine storm that gets released by the brainstem, and then you get all these other issues downstream. So there is some physiologic reason for doing some of these things. It's not because we're worrying about how the patient is sensing things at that moment. Jordan, did you have a?
I would say that in countries like Australia and the UK. Thank you. No, I would say that in places like the UK, NRP has been kind of put on hold for the moment. And that's because in the UK, they have this linked definition of circulatory and brain death. So they say that circulatory death will commence, but brain death will follow. Here we have two standards. We have the brain death standard, which is very specific, all functions of the brain and brainstem, versus circulatory death, which is a different standard, but they're not tied. So brain death does not necessarily have to follow circulatory death here. So that's why NRP is legal and ethically permissible, whereas in UK and Australia, it's not.
Right. There was a lot of debate last week at the ISHLT about the different countries and it's like, it's what the definition of is, to quote Bill Clinton, but like, are they dead?
Or almost alive.
Or almost alive.
Thank you, Dr. Kazani. That was a wonderful grand round. Thank you all for coming. We'll see you guys next week.